diseases by epidemiologists and virologists, which is used to respond to outbreaks, are only as good as the assumptions that they're based on. These assumptions needed to be tested and nuanced from the perspective of a wide range of disciplines. Social scientists can bring their expertise to bear on questions like if and when people will tire of interventions like physical distancing, or issues of how social difference, social class, or location will affect people's ability to respond to public health interventions. We also need to engage communities in meaningful ways. Learning from the Ebola outbreak in West Africa in 2014 to 16 shows how very important that community engagement is, particularly when trust in government is low and health systems are weak. In circumstances like that, it's often community forms of organising that can be invaluable and indeed most effective. For instance, in Sierra Leone, in Ebola, we saw community-led efforts around adapting burial practices and quarantining being really critical in turning the epidemic around. We obviously need the knowledge of medical scientists, natural scientists, epidemiologists, but we also need social science, and we can look valuably to the knowledge and experience of community members across the world. For instance, at the moment, we're seeing how people living in informal settlements are collecting data about their own lives and livelihoods that could inform workable disease response efforts in those contexts. We need to connect up learning of that kind with national and regional and international response efforts if we're to produce responses that actually make sense and are therefore effective in the real settings in which people live.